Each one of us is equally guilty. Think of what happened the last time you had a sniffle. You went out, picked up a pill, popped it in the hope that you wouldn't fall sick and would be able to get back to work. Just keep adding up all those pills and what this could mean when you end up at a hospital. I want to show you some figures. Take a very close look at this, because there's a WHO study. There are other doctors across the country who've been researching this. They say 50% of the antibiotics now are either misused or overused. Patients don't complete their full prescription, are using pills indiscriminately, as a consequence of which 70% of the patients who are now going into intensive care units are found to be immune. 70% are found to be immune to antibiotics. 30% of the infant death that happened because of non-responsive antibiotics. Not just is this generation being impacted, also the next. Another figure, 95% of the infant death happened from non-responsive antibiotics. I want to bring in, to discuss this further, our guests for the show that we're doing this evening. I want to begin by introducing first Dr. Sumit Ray. He's the Vice Chairman of Critical Care Medicine at Sir Gangaram Hospital in New Delhi. He tracks bacteria that is resistant to antibiotics very, very closely. I also want to introduce Dr. Sanjeev Bagai, Dean of Radiant Life Care. To give us a consumer perspective, Bijon Mishra, founder, Partnership for Safe Medicine India, consumer rights activist, and Damayanti Datta, deputy editor of India Today magazine. She's been working over the last few weeks trying to put this cover story together for us, this publication. I want to ask Dr. Bagai the first question about how serious is the scare, because this is something everyone watching this broadcast would say, I have done it at some point in time. Without waiting for a prescription popped pill, you're meeting patients on a daily basis. How big a scare is this according to you?
I think the scare is real. If you look at it rationally, the advent of antibiotics in the last century or so was the greatest discovery in healthcare. But I think overuse of antibiotics may turn out to be the greatest catastrophe for us as doctors in healthcare. The fear is real as far as hospital-acquired infections is concerned. Non-response on routine OPD patients are concerned. The scare is real because the patients tend to self-prescribe medicines, and very often chemists turn out to be the local best doctor, which is free of cost for them. And very often you don't require prescriptions, you don't require valid prescriptions. In any Western country overseas, if you require a prescription drug, it is validated for that many number of days. Here you can use a 2010 prescription in India till 2013 and still get the medicine. And lastly, I think the public awareness campaign needs to be launched. I'll just take a minute on this. In 2012, as recent as 2002, 11 years back, France launched a national campaign in which it was a national media campaign, print and electronic, that antibiotics are not automatic. And it really cut down the overuse of antibiotics in France.
Over here, there's lack of awareness as well. People think they're doing the right thing.
Yeah, we need to tell the doctors what the correct medication protocols are. We need to inform the patients that you need a valid prescription, and chemists definitely need to be coming under stricter legislation and regulation.
Dr. Sumit Ray, when the superbug was discovered, it came out in a Lancet research paper, everybody dismissed this as a conspiracy theory to try and debunk medical tourism in India. They thought that that was the reason why Western hospitals were striking back, and this was part of that larger conspiracy. But the work that you've been doing over the last several years now indicates that yes, there are superbugs that are completely resistant to all known antibiotics.
Absolutely right. I mean, the worst thing that you can do is to behave like an ostrich and stick your head in the sand and say that this problem doesn't exist. It is true that the problem exists, and what we found in our study is that in people getting infections from the community who end up being in hospital and ICU, 70% of them are resistant to fourth generation antibiotics. Okay, 70% of them, which is huge. And these are people from the community. It's not hospital-acquired infections. Hospital-acquired infections anyway are very, very resistant.
So what does that mean?
Which means that...
Just try and I want you to keep all the medical jargon on the side so everybody's understanding.
Right.
Everybody who's watching understands what you're saying.
And what is fourth generation?
Basically, almost the latest generation of antibiotics they're resistant to because there has been an overuse of antibiotics. It's very easy to blame patients. It's very easy to blame chemists for this problem. Yes, part of it is that, but we as doctors ourselves sometimes overprescribe. we really overprescribe antibiotics. We are almost pushed to the point to a certain extent because of the way healthcare is delivered in this country. Unfortunately, almost 78% of healthcare is private healthcare in this country. So there is an urge to cure the patient quickly, and you bombard the patient with multiple drugs, leading to antibiotic resistance. And it has been seen that countries which have a better public healthcare system, which are not under pressure to deliver quick care, do much better in antibiotic resistance.
We've also seen over the last few years several stories of a nexus, a collusion between the pharmaceutical companies and doctors in clinics who want to prescribe because they get a cut, and as a consequence they are prescribing maybe stronger medicines than are required, or giving them a longer duration, all of which could actually end up with a patient becoming immune to antibiotics.
Absolutely. You see, what we have observed is that I remember my childhood days, a medical practitioner would rarely prescribe you a medicine. Only on extreme cases they would do that. But what has happened now, the psyche, the trust between the patient and the doctor is no longer there. There is no counseling from the doctor's end. And they just overprescribe, irrational use. And the biggest challenge is the patients are unable to access a doctor. My study which I did in 2002 for the National Pharmaceutical Pricing Authority revealed more than 67% of the patients were being prescribed by chemists in the neighborhood chemist stores. You see, and what can the patient do? They can't access a doctor in a primary healthcare center. Doctors are not there. And you see, in our country, Medical Council of India, do they ever do a prescription audit? It is never done.
But at some level, each one of us is also to blame, because the moment you start feeling better on the third or the fourth day of your prescription, you stop taking the antibiotics, saying, I'm fine now, regardless of how this might impact that same bacteria in the future.
Nobody has taken the trouble to counsel the patient, number one, that please do not do self-medication, please do not buy medicines without my prescription. Which doctor spends that time counseling the patient? Today, none of the doctors I've seen are having that time to look at the patient in a manner that was existing in India. The value system has changed. The medical profession has become commercial. It's an industry now.
It is an industry, but a lot of patients also, Damayanti, actually self-prescribe. They think they know it all, or they'll have somebody, they just speak to him on the phone, pick up a pill, pop it, in the hope that they'll get better. So everyone, whether it's a chemist, whether it's a doctor, whether it's a patient, everyone needs to look at this and not take it lightly.
Absolutely. And I think, sir, what you're saying is not really true. Most of us know that we should not be doing this, but still we do it.
I fail. You see, I'll tell you, I have been talking to consumers on this issue. That why are you... The first thing the consumer says, where do I get a doctor? I don't have time. I can't wait in the clinic for 4 hours.
How does this problem compare, Dr. Sumit Ray, in India vis-a-vis elsewhere? Because the India Today study elaborates how this is more chronic in India. Why is it that this problem is more acute in India than it is elsewhere?
Right. This problem is worldwide, primarily more in India, places like India, where, as we discussed, is over-the-counter medication. Second, inability to access healthcare. You end up accessing medicine through the chemist. Inappropriate use of antibiotics in hospital, outside the hospital, no policies at multiple levels. Blaming the government is easy, but yes, the government, it is necessary to have a policy, antibiotic policy for the government. Also, infection control practices and antibiotic practices within hospitals, among doctors. There has to be certain antibiotics which has to be restricted only to hospitals. It cannot be used other than inside hospitals.
No, but one of the other things that your study points out is about how patients are picking up these resistant bacteria even inside government and private hospitals. So what can a patient do inside a hospital? Because here's where he's hoping that he's actually in good care, sir.
Right. See, this is the problem worldwide, that infections which are acquired in the hospital are usually more resistant because these are sicker patients who have been on antibiotics, so the bacteria have become more resistant. The problem is, when does it become worse and worse, is that when the antibiotic usage in the community also increases, then we see that what we found in our study is those people coming from the community with no exposure to the hospital are getting very resistant organisms. And obviously those organisms which grow in the hospital are even more resistant. So it becomes a vicious cycle that
I'm reading over here where you say that because patients use the ventilators, given how bacteria prone, those ventilators are, a lot of this resistant bacteria actually comes from just being in a hospital. Now that's very, very scary, Dr. Bagai, for inpatient.
See, infections which are within the premises of a hospital are basically of two major verticals. One is hospital-acquired infections, which is of admitted patients, be in the ICU or the wards, or who've had procedures, surgeries, or who have been on ventilators or have catheters. And second is patients who come in from the community. Now, the net result is, one is control of hospital infection, that is hand hygiene and washing and aseptic care. But the very major chunk of infections is because of a very prolonged and a very rampant overuse and irrational use of antibiotics. There is sufficient worldwide data to show most sore throats do not require antibiotics. Most loose motions and vomiting do not require antibiotics. In fact, they don't even require a probiotic. It's self-limiting, it's transient, and it goes away. I think here the patient education and the doctor education is extremely important. For every inpatient which is admitted, we would probably see more than 35 to 40 or maybe 50 outpatient patients. That means the ones who come into the clinic and are sent home without being admitted. This is the largest patient population which requires proper legislation. I think what Sumit has said is right. There is a certain group of drugs which should be available only in a hospital setting and some for a non-hospital setting, but the ultimate choice of a use of antibiotics rests on a clinician. So therefore the message should go to the clinicians, to the family physicians, to the general practitioner, who very often is the first point contact with the patient.
What I would like to do, and that's one of the key things that everyone watching this broadcast this evening, concerned about the pills he's been popping, would have is, how do I know that my body is actually becoming resistant to antibiotics? And Dr. Bagai, if you could just step across with me.
If I have that, bacteria,
then what are the symptoms? If you can just come across with me and explain to our viewers what needs to be done. How is it that viewers can pick up that their body is now becoming resistant to some antibiotic or the other? Our producers have actually put together a whole set of graphics. If you could come across that side, please, Dr. Bagai, and explain each of these symptoms as they play out. This is the first symptom that's been put together by the India Today story, which says fever for 3 days despite antibiotics. That's symptom number 1. Can we take symptom number 2, please? Spiking fever despite falling blood pressure, seizure. That's symptom number 2, that your body is becoming resistant to antibiotics. Persistent diarrhea, unnatural stool. Symptom number 3. Can we take this forward, please? Swollen lymph nodes. So how is it, if as we go through these, how is it that patients can actually figure out that this is the problem that they're having? Extremely severe headaches. Because a lot of these things could actually happen to anybody at any time. So for example, if it's headaches, how often should you be having this headache to maybe come to the conclusion that your body is now becoming resistant?
If you can just come down to the first symptom. So we'll
let's take it one by one. Shiny skin, rashes, or painful blisters. That's now, symptom number 6.
Most antibiotics can cause reaction. Sometimes the reaction is self-limiting. If the antibiotic is used in the correct dose with regards to the age and the body weight of the patient, or if the antibiotic is used for the given duration of time. Now, if a fever is lasting despite antibiotics, which is symptom number 1, I think the patient should take a review from a clinician and make sure, are we missing out anything in first point as a clinical diagnosis.
So the first thing, if you've been having an antibiotic prescription for more than 3 days and your fever is still not coming down, that could be symptom number 1.
And also, in case we haven't done any lab tests, this is another common mistake which most doctors or most patients make, is there are no cultures sent. Antibiotics
but there's also, doctor, a big trust deficit between patients and doctors, because now so often doctors order tests where if you go to another doctor, they'll say, no, actually the test was not required. So patients are then very suspicious of all doctors.
You need a rational use of lab tests before starting antibiotics. Say for example, swollen lymph nodes or diarrhea. Now these are symptoms in which the body is abnormally reacting to antibiotics. It can be one antibiotic or 2 antibiotics. Severe headaches, again, routinely patients will not have severe headaches if the patient is well or responding to antibiotics. Now this is something which shows like a reaction on the skin. So this is turning out to be a hypersensitivity reaction towards antibiotics. So this can be a very dangerous symptom as far as patients are concerned who've been using antibiotics for a very prolonged period of time. Now the symptoms as far as the abnormal reactions to antibiotics can be diarrhea, vomiting, loose motion, rashes, headache, mucousy stools, weight loss, persistence of fever, and so on. I think it's also important when you come to an abnormal reaction to antibiotics is if the patient is clinically not responding. So I think the message is to the doctors, the message is to the patients, and overall to the community that antibiotics should be used rationally.
No.
There's a very old saying, Rahul, the first rule of use of antibiotics is do not use an antibiotic. And the second rule is use a single antibiotic. And the third rule is use it for as minimum duration as possible.
No, but Bijan, if you can just go back, please, Dr. Bagai. You know, the doctor says that you should get tests done so as to know what your problem is when you're feeling unwell. There is now a big trust deficit between private hospitals and patients because doctors tend to order all manner of tests because they make money on each of the tests, and therefore patients are now, and you go to another doctor, he'll tell you, no, actually you didn't need this test, you didn't need that test. So patients are now very concerned because they think they're being taken for a ride. In most cases, they are being taken for a ride.
And absolutely, and there are a number of evidences which has revealed this. You see, in our country where the nexus has, now in the Indian Medical Association has come very strongly to, you know, sort of expose these kind of nexuses, and they have brought in a mandatory regulation that they have to now reveal that to whom they are paying, how much money they are paying, and in what manner they are paying, for what purpose they are paying. So all this has now come into the domain. But let me tell you, Rahul, the most important issue is that there is a great, you know, need for a strong regulatory oversight into these kind of issues. The regulatory mechanisms at the state level and at the central level are not doing anything in terms of understanding how the chemist is behaving in terms of dispensing medicine, the good, you know, practices in terms of distribution, in terms of medication, in terms of good practices within the hospitals. None of the hospitals are ever visited. I have reports which has revealed that they have equipments which are non-functional. So if you keep an equipment and get your hospital accredited because you just have an equipment which doesn't even perform, then what is the use of such equipments to take care of the patients? And they pay enormous amount to get a treatment.
So, you know, the health minister has suggested warning labels on possibly these are going to come. Do you think they're going to work?
Again, you see, the point again is, you know, as Dr. Bagai said, that there has to be a strong consumer awareness campaign. You know, like our Jago Grahak Jago campaign which started, you know, in the country in 2006. And what we need to do is to build a kind of a huge, see, no medicine which is for to be sold with prescription should be seen being sold without prescription in India. This is one of the strongest needs which needs to come today.
What is most eerie, Dr. Ray, is that in 1945, Alexander Fleming actually predicted that there would be a bacterial backlash as a consequence of antibiotics. He warned that indiscriminate use of penicillin would lead to the creation of mutant drug-resistant bacteria. Now, 70 years later, what Alexander Fleming said is actually coming to be true.
Yeah, that shows his brilliance. I mean, he was a brilliant scientist, and that is true, and that is what has happened. And as you asked previously, that why more so in India, it is particularly because of uncontrolled, unlicensed use of antibiotics, and the level of legislation has to start from the top, where the government has to legislate that there are certain antibiotics which can be used, as I said, within hospitals, certain with prescription, and probably a small number which can be used without prescription. One. Second, there has to be infection control policies in regions and in hospitals. And also, very important, what we are forgetting in this whole debate is access to good public health care. See, finally, if people access public health care,
government hospitals are as much of a mess as private hospitals. It's not as if I feel any more confident going into a government hospital. I actually feel more scared, sir.
No, that's not the point. It's not about public hospital or government hospital or private hospital. The point is, if you have access to better public health care, not hospitals alone, but PHCs, etc., the tendency of government doctors to prescribe excessive. Anyway, antibiotics are controlled in the hospital that you're getting from. The dispensaries that are dispensing public health systems will be better. Obviously, there has to be an accountability of the public health system.
You keep making that point. I want Dr. Bagai to come in because it's the private hospitals, Dr. Bagai, which are
I'm part of the private hospital system, but I still believe
which are a big part of the problem because doctors get commissions from pharma companies. So therefore, it's in your interest to prescribe the costliest drug to make the longest prescription, so that at the end of the day it comes into your salary, sir.
Finally, when you see,
not a fact, Dr.
when you see a patient as a consumer,
it's in two folds. I'm not saying that all doctors are clean or unclean. The point which I'm trying to make is that most good private accredited hospitals have two basic things. One is a very stringent hospital-acquired infection control committee, which works. And point number two is we have a committee for rational use of antibiotic policy. The segment which still remains unmonitored are the patients which come on outpatient basis. They go home on a host of antibiotics. That segment is still unregulated. And where is the medicine being procured from? Be it a pharmacy, be it a clinic.
I have some figures I want to share with our viewers. A study done by the World Health Organization shows that 53% people take antibiotics without a doctor's prescription, and 18% save it for later use by themselves or by family members. That, Dr. Ray, should never happen. If you've got an antibiotic, you throw it out, you know. You don't keep it for later. I think almost everyone watching this broadcast will say,
Absolutely.
I've done that at some point in time.
I agree. I mean, it's at two levels. One level is people who can afford to throw it out and buy new ones when necessary. Okay. So that is access to healthcare. Obviously, we are people who probably have no problems doing that, that when we use off the course of antibiotics, the rest remaining we can throw off. But as I repeatedly am trying to say, is that there are a large percentage of population of this country who do not even have access. And when they buy those antibiotics, if they have to buy, that makes them bankrupt. And obviously, if they are left with a couple of antibiotics more than they used, then they will try and use it later, because buying antibiotics by itself is one of the most expensive things. Almost 70% of outpatient care cost is because of buying medicines, out of which almost 40% is antibiotics.
No, but there is a larger problem
Yes.
that we are confronted with. The problem of modern medicine actually not discovering any new powerful antibiotics. Part of the story mentions that since 1987 there has been no major antibiotic discovered, Dr. Bagai. Why is that?
I will tell you. If you go back, and most patients would, and most viewers would correlate with this, that the best kid on the block, as a new kid on the block in late 70s and early 80s, was a medicine known as ciprofloxacin. I'm not taking any company name, the generic group is ciprofloxacin. And it was supposed to treat a host of infections. Now it has become completely resistant to the most common infections such as typhoid in the pediatric age group. The same thing now is going to happen to drugs like norfloxacin and so on. If a patient has even one episode of diarrhea or vomiting, before even calling up the doctor, he would say, I have already started on this, is it okay? We say it in our practice every day. So I think awareness, information of the correct degree to the correct point where it needs to be given is the message, is the need of the
No, but over here, the fact also is that so many doctors prescribe medicines for common cold. There's so many illnesses which don't have a medicine, and the doctor gives it, no, because he's making money out of it. Why won't he give it?
to prescribe medicines.
But doctors do it.
That's what I'm
Action
saying.
should be taken against such
And
doctors.
that is where I'm again trying to bring, on this show of yours, that there's an urgent need to do prescription audit in
Absolutely.
India. We must take stringent action against medical practitioners who are irrationally prescribing to the patients, making patients victim of such huge financial burden.
We have some figures over here in this study. 70% of doctors prescribe antibiotics even for common cold when there is no known cure for common cold. And 50% of the chemists sell antibiotics without prescriptions. There are
Absolutely.
holes at every level, doctor.
Coming back to your point about why there are not enough antibiotics coming in the pipeline.
Yes.
From the industry, pharmaceutical industry, big pharma. They are the ones who usually bring out the antibiotics. Two reasons. One of them is that the highest profitability for drugs for pharmaceutical industry are what are called the blockbuster drugs, are usually not antibiotics. They are like statins, your cholesterol lowering drugs, your antihypertensives, which people have to take for lifelong. So obviously the enthusiasm.
Make sustained money.
Yes.
Over a long
So
period of
pharma
time.
industries, whatever they may claim, is not there to take care of you. They are there to make profit, and they are the second biggest profit makers in the world as an industry, second only to oil. Okay, they make 19.1% their profitability on.
I like how candid you are, because that's how doctors should really be. Tell the truth for what it is.
19.1% is their profit on revenue, second only to oil. Okay, so this is the reason why antibiotics probably.
And this is the point which I want to bring in, that these are doctors who need to be recognized by the community, so that patients like us should know which doctor to depend on.
No, but everybody is busy making money. Why would they
That's what
try
I'm
and
saying.
signal
So
anybody
even
out?
if there are a few, we should be able to recognize them in our community. And you know that, you see, there are magazines in countries where they say, know your neighborhood doctor. And those magazines actually carry such stories where people have come back and said that I got treated without any antibiotic or without any very expensive medication, and these are the doctors who should be believed on. So you see, these kind of a movement should start where the trust, which is lost, comes back.
You know what? There's a lot of traveling happening. The world has become smaller, and apparently it's the closed atmosphere of a flight that's also responsible for a lot of drugs. I mean, bacteria.
How does that impact, Dr. Bagai, medical tourism? Because a lot of patients internationally have been traveling to India. When they see that you can pick up resistant bacteria from a ventilator, from a pan inside a hospital, is that impacting their desire to come to India?
How much?
Antibiotic resistance and these so-called superbugs actually have been in existence in every continent, in every Western country also. I still feel that India was wrongly blamed by the terminology of why it was called as New Delhi Metallostrain 1. It doesn't take away the fact that drug resistance and bad superbugs are existing in the Indian setting. I don't think this is going to have an impact on the medical tourism as such. We have more than 5 lakh patients which have come in the last financial year, and the industry is growing at more than 25 to 28% across the board all over India. This sort of superbugs, in fact, the one which was labeled as the patient which had this bug as the Metallostrain 1 was a Swedish national who in fact had visited Pakistan first. So India was actually hanged for no fault of its own. Coming to the question which was just previously asked, a drug through R&D before a new antibiotic comes in takes more than 5 to 7 years of very intensive research. More than $10 million goes into researching one new molecule. The molecule need not remain with that pharmaceutical company for life, as far as patency and things is concerned. So there are a lot of other commercials which are also involved in the newer antibiotics coming.
This is the stuff that you see often in Hollywood films, and we've seen parts of it already where tuberculosis, an illness where everybody thought they had a grip on it, they could cure it. Now there are strains which are resistant to tuberculosis. There is a worst case scenario that's been predicted in some of these movies, which actually seems like it's out of a Hollywood movie, where there is a massive disease. It almost spreads like an epidemic, and all the antibiotics at that time are not able to deal with that virus, with that bacteria. How real is that threat?
That can be pretty real. But before that, I would just like to respond to what Dr. Bagai said about naming it an NDM1. Well, there has been Verona virus which was found in Italy. So there have been names of places which may be unfair, but there have been names of places before in antibiotic resistant organisms. Second is that, again, as I said, we try to deny it. Okay, is reducing medical tourism our problem economically, financially for this country, or is a resistant bacteria, more resistant bacteria with overuse of antibiotics going to be a more health and economic problem, because you are going to increase the cost of healthcare? So I don't care if medical tourists don't come. To tell you honestly, it is more important that we have better antibiotic control practices, etc. in place, so that we don't spend too much more money on our own healthcare system.
I want to ask you that question about how real is the threat of an epidemic where people have a strain of bacteria which antibiotics known at that time, no matter how powerful, simply cannot deal with.
It's already there.
It's real.
It's real. It's already there.
It exists. I mean, that's a no-brainer. The fact here is that even in US,
it is already there.
More than 99,000 patients die every year because of drug-resistant infections.
But we don't
in European Union,
but the tragedy is in our country, there is no database. The patients are never even given their history.
No, Bijon,
you see, when they go for treatment, they can't take a history back that how and in what manner they got treated.
No, I will tell you why I'm giving these statistics.
The patients have to live with such kind of a dominance by the medical fraternity. You have to understand that we as patients have the right to know that how we got treated.
Okay, quick final point.
Yeah, now when you are having more than 99,000 patients in US per annum, 25,000 patients in EU per annum dying because of this sort of infection, US alone is spending $1.7 billion on treating these sort of resistant infections. These are proven statistics. Our drug-resistant infections must be coded. So we, at the time of discharge, must give a code to this type of infection. The reason is we must gather our own database as far as what is the true risk into percolating tertiary care, secondary care and primary care.
A very strong tracing and tracking mechanism has to come into place.
This is very, very seriously scary. The report that Damayanti has put out about how more and more antibiotics are now almost becoming placebos. They don't have the impact that they did a few decades ago. And the worst part is, given how antibiotics are being overused, this is only likely to get worse. You've held out messages for chemists, for patients, for doctors, for the government. I hope that message goes through, because you're also saying that there is a very real threat of an epidemic not very far away in the future, maybe just right around the corner, where people die, maybe lakhs, maybe millions, we don't know how many, because antibiotics don't work. This is something that everyone needs to work on together. It's the biggest medical scare confronting our nation, and I'm glad that we've been able to put this story on center stage tonight, although I'm sure immediately on the back of this show I'm going to get a call from my mother, who will say, next time you have a cold, do not, for heaven's sake, just pop a pill, because that's not required. And I hope everybody really takes that message to heart. For the moment, to all my guests for joining us on the center stage face, thank you very much.
Great show.
Thank you.